So thank you very much. Very pleased to see everybody here. I have the pleasure of presenting Dr. Susy Stark, Susy, right? She's a professor of public health, and she previously was a professor in occupational therapy and also neurology and social work. Susy's work is aimed at helping older adults live independently for as long as possible. She conducts translational research and clinical research to promote successful aging in place and prevent falls. I hope that wasn't personal, but the lights would be. Much of her research focuses on older adults with chronic health conditions, implementing evidence-based interventions to compensate for impairments through environmental supports and self-management strategies, really all geared towards mitigating functional decline. Her research also involves developing and testing the efficacy of compensatory interventions to enhance older adults to safely age at home and clarifying how the interventions work. She has contributed to public health for a long time through her teaching roles, through her mentorship in her lab and other places, other programs, and has also worked with the TL1 pre-doctoral training program through the ICTS. She also teaches in When I'm 64, I'm Reimagining Your Future through the Beyond Boundaries program at Washington University and serves on their advisory board. She has her bachelor's from Alma College in Michigan. She has her master's in OT from WashU, and she has her PhD in environmental and behavioral science from Columbia University of Missouri, which I didn't know any of that. So this is great, and very pleased to have you here today. I think we're supposed to use that.
Okay. All right. Thanks, Deborah. That was really nice. I really appreciate the introduction. Thanks everyone for coming, and hello to those of you on Zoom land. I hope you are able to hear us. Just send us a little brief comment if you can't hear us, and we will make sure I repeat questions for you. I'm really happy to talk to you all today. And now you're all fuzzy, so my anxiety level goes down a little bit. So just yell if you have a question and I didn't see you. But I can see my notes now. So I'm going to talk to you about home. You've all heard Dorothy say there's no place like home. And as a clinician, I worked for a long time before I became a scientist. And I always think about the things that my patients said to me, which were always never things like, I really want to get to a nursing home, Susie. They were always telling me, I really, really, really want to get home. And so that kind of sparked my interest in how we can help people age in place successfully and live out all of their best years in the place that they want to live. So to get started today, I'm gonna advance. Of course, I said if there's any technology that can be broken, it will be me. Do you think I can just hit enter? Here we go. Perfect. So let me tell you a little bit about our group, the folks that do this work with me. So we have about, at any given time, 9 to 10 to 12 trainees, and those are occupational therapy students, medical students, students in public health, applied health behavior research. We have folks that come from Mahari. We have folks that come here to work with us. We have postdocs. We have great, early faculty from across the country that we work with, that we love hanging out with. We have a very strong community advisory board. Some of them you see here when we were celebrating Valentine's Day last year. We have at any given time about 15 older adults who I give full credit for all that we do, because they tell us what to do, we listen, and they help us be super successful. So our advisory board, we have about 10 staff, some of whom are here today. Thanks for joining. And well over 1,000 older adults that we've worked with over time. And we keep them on our board because they always sign, almost all of them say, if you have any other studies, please let us know. We still want to hang out with you. So we have a lot of older adults that we love. The older adults live, if you're from St. Louis, you probably recognize this map. It's a map of anything that has to do with any health disparity. So if it's poverty, the folks in the red blocks have the highest rates of poverty. If it's lowest rates of screening for something like breast cancer, or the last to get a COVID vaccine, it's usually folks that are in those red blocks. And those red blocks are also where the folks that we study live. So today I wanted to talk about a couple things. First, to give you a sense of who we are and what we do, kind of our lens. We obviously aging, disability are things that we're interested in. So kind of the who, the what we do is we focus on environment. And then the how we do it is community engagement. So talk about that first. Then I want to talk just about a few exemplars of some studies that use this lens and what we do, and then maybe kind of impact and where we're going from here. So that's our plan. We'll see how well we do. So the first thing that you're looking at, and I love watching this, so I'll let it run a few times, this animation shows the US population distribution. And what you'll notice when we start in 1933 is it was a pyramid. So we see the pyramid change over time, and that reflects kind of as we look at age on the y-axis with the population, on the x-axis, you can see that over time, we have had an increase in the number of older adults. This is we call it from going from an aging pyramid to an aging column. This has a lot of implications for our society. It means number one, that we don't have as many young people taking care of the old people that we've had since the 1930s, 40s, and 50s. So it really helps us think that we need to change the models of how we're going to address aging as a society, especially when it comes to health. So I think a lot about the population of older adults. For me as an OT, I often, this is the American Community Survey, and this shows us that the older you get, the more exposed you are to things like chronic conditions, and the more likely you are to have some type of disability. So you see for folks that are 75 and older, those are the folks that we are interested in hanging out with, you start to see a high level of disability in this population. So this is, since I study the environment, this is really important, because the thing that I know that goes along with those older adults that have been living in their homes for 50 years, the homes that they bought post-World War II with their GI Bill, those homes were not designed to support them aging in place. And only 1 out of 10 homes in the US has any kind of accommodations that help people stay safe and independent at home. But 89% of them every year when AARP surveys them say they are going to stay and age in place in their home. So that sets up a problem that you can begin to see that we are interested in exploring. So the other thing that's important to understand is that home occupations, and I have so many patients that are surprised when I would tell them this, home occupations are not provided as standard of care for health. I hung up my white coat and got my PhD when I got into an argument with an insurance company, because I explained that the person that I saw that just had a hip fracture that had this bathtub and could no longer get in safely because the tub was too high and they couldn't step in. They were requiring a bath aide to come in every day. And I explained to them, if I just put in a $250 bath bench and a handheld shower, the person would be independent. And the insurance company said, sorry, that's going to be on the older adult who lived in one of those little red boxes and didn't have the resources to pay for a $250 bath bench. So that kind of started my journey on exploring what we can do to improve health systems to make sure that people can live independently at home. So about the same time, I was really interested in understanding, not just as we have in the past, alive or dead, yes or no, or maybe moving on to ICD, had a stroke, yes or no, but what are the consequences of living with a disability? We've not been very good at understanding that until we invented this new classification. Just for those of you in the audience that are thinking about how to build a career, classification, not the sexiest way to have fun spending your time, but it was really important to me to begin to understand there are consequences to living with a disability. We should measure them, or with a health condition, and we should measure them. So the World Health Organization's ICF is the companion to the ICD that was published I think in 2001. Helps us understand that health conditions are impact body function as well as activity and participation. But there's also other factors that are involved with those distal outcomes, such as participation and activity, which I was very interested in as an OT. So if you have somebody whose health condition is not going to change and whose body structure and function is not going to change because they have a chronic condition or they're aging and they're not going to see improvements that we might see with younger folks, the environment becomes an important lever that we have as an intervention. So this was an important step for us. So I like to think of it this way. It's a social model of disability versus a medical model of disability. So you really are only limited by the context that we provide for you. So you might have a spinal cord injury, but if we put you on the right smooth surface with a racing wheelchair, your mobility exceeds mine for sure. But if we put you in that same wheelchair, the same person in front of a set of stairs, that is where the disability starts to happen. So that's the frame that we use when we think about how we can help older adults be independent. The other thing that happened to me early in my career was I was hired for a postdoctoral type position by a person who was quadriplegic, and we studied disability. And I didn't realize, and I just thought everybody had a lived experience perspective when they did research. And I didn't realize the value of those early years of being with people who had disabilities, studying disability to understand that lived experience. So when I became an independent investigator, it became really natural for me to continue to work with the folks that had the lived experience. And so we have three really, I would say they were accidental engagement strategies that happened in our lab over time. The first is that I came as a clinician, and so I continued my connection with all the clinical folks and the providers in the community that I was working with. So being engaged with stakeholders and providers was natural. So we have really strong community partnerships with agencies. We soon wanted to still hang out with the older adults that we had enrolled in our studies. So they all joined our advisory board, and we've had a vibrant advisory board for well over 20 years now that work with us on a regular basis. And then a few years ago, we started to link together our community partners across the state, and we modeled a community-based research network on what was formerly what I've known as a practice-based research network. So the idea that you link physician practices across a community with academic scientists was really appealing to me, but I didn't have a lot of physician practices. So we used our community networks and invented a new thing called community-based research networks that links providers across the state of Missouri who are interested in aging and disability. So this is just gratuitous photographs of our cool advisory board, because I kept looking through them and I kept finding more and more photographs of the amazing folks that we've had over time that help us invent interventions, that advise us about our studies. But I do think that it was important. A few years ago, one of our students got funding from the Gephardt Institute, and we started a new role for our community advisory board, and I began teaching with them. So every class that we had with our students, older adults would join the class. Nothing about us without us was our mantra. So we took that into aging, and the students have loved having older adults teach them. I've loved having older adults keep us all honest. I've also noticed that students listen to older adults before they listen to me. And so they have some pretty sharp skills for how to do a poster session, specifically about speaking up so people can hear you in the back of the room, which is terrific. So these are some of the images of some of the older adults that we have hanging out. We will go to their homes, we will pilot interventions with them. We hear all the bad things that we've done, and they help make us better. So our Aging and Disability Research Network moved from one of my research studies to now it's a core service for the Institute for Clinical Translational Science. So if any of you are interested in studying aging and disability issues across the state of Missouri with independent living centers or with area agencies on aging, this is a really interesting population because they're not a group that generally hangs out in a hospital or in EPIC. So we have access to these individuals, and we understand the issues that they have, and we have a really engaged group of providers who are interested in connecting with investigators. So I point this out as a potential resource for folks who are interested in studying this group. So I'm going to shift now and talk about a few exemplars and kind of show how we've used this lens to conduct a few studies. I'm going to just say the thing about developing a career that studies a strategy versus a population. There was no National Institute of the Environment that I could go to figure out how to fund my studies. So I have been I visit lots of different institutes and I study lots of different conditions, which is great if you're a polymath, and it's really hard if you have to write a grant and learn a whole literature about Alzheimer's disease if you haven't done that before. So just pointing that out for trainees in the room that might be considering a career. This is really fun if you did take one of those career surveys and they identified you as a polymath. If you are bored with one disease, go to the other, learn the literature. It's really great. But I'll just share two with you today, specifically about fall prevention for older adults with chronic conditions and stroke. So this is where I get on my soapbox. I was stunned as a provider to realize I knew so little about falls and the impact that they had on older adults. So falls are the leading cause of injury and injury-related death among older adults. They are the leading cause of fracture. They are the leading cause of brain injury. Falls can also result in a fear of falling that causes people to reduce their activity and limit what they do, and then causes this downward spiral of loss of function and loneliness and depression. Falls are one of the scariest things that we've seen happen. And whenever I talk to people at any event and I tell them what I do, inevitably I hear a story of just great sadness of a family member who's sustained a fall. It is one of those things in our society that we spend very little time talking about. We talk a lot more about seatbelts or tobacco, but we don't talk about falls and the consequences they have. So I think it's one of these big problems that we have. And if we don't care about the social consequences or the health consequences, before she left the CDC, before the falls group was eliminated, my friend Gwen Bergen did an analysis of the consequences of falls. So not the people that die from falls, the consequences of living with a fall consume 9% of the Medicare budget right now. And it is on track to double the actual dollars that we spend, I think by 2030. So it's a stunning economic cost to our society as well as a personal cost. What do you think about this? The thing that is really frustrating to me is over a third of falls are preventable. So because we know 1 in 4 older adults are going to fall 65 are going to fall every year. We also know that about half of those falls occur at home. So if you kind of think about what I told you before about the lack of support that people have in homes, it becomes really interesting to me that this could be a potential lever that we could have to create supportive environments to prevent falls. So we knew that this intervention had success in Australia and in Europe. We hadn't brought this service to the US because it's not typically covered as part of insurance. Home modifications and having therapists do fall prevention in the community are not part of how our system reimburses for care. So it wasn't covered. So we don't have a lot of therapists that know how to do it in the US. So we invented an intervention called HARP based on these Australian and European models. And we know what goes into a good intervention. We've known from their literature that it needs to be an evaluation of individual abilities. So if you've seen one home hazard removal program, you've seen one home hazard removal program, because everyone has a different set of abilities and everybody's home looks a little different. So we never go in with a set of 5 activities that everyone gets. It's always customized or tailored to their unique profile of abilities. So the therapist observes the person in their daily home, identifies their hazards, and then works with them to remove hazards. It doesn't work to just give people a list of things to do and by good luck, maybe your son can install this for you. So we know those things work. So it also helped for me about that time that I had, Ross Brownson was my mentor for my K Award, and he would say things like, Susie, why don't you design it to be implementable in the first place so we don't have to spend so much time on the backside trying to figure out why things won't work in our system. So taking that advice, we set out to try to think about what the potential barriers would be for implementation in the future were we to do home hazard removal in the US. So we were lucky in a sense that we were behind the times at this point because we could try to design something that would fit within our system. So the idea, and I see lots of these in my days, trying to resolve environment, is solve the problem before it's a problem, to think through the problem. So we thought carefully as a team. We had lots of experience on our own. This is an example of, was called in because this person had received 5 or 6 tub benches and still wasn't independent and bathing. And when I went to her house to visit, no therapist had ever set foot in the house. So all the tub benches were piled up in the living room. So I've seen things like that. I've seen things like this person has an accessible apartment. Why are they still falling? And when I go to the apartment, yes, there are grab bars, but they'd also turned that yellow arrow is pointing to a beige tub from Target that they turned upside down and were using as a back bench. So the tub that you store your sweaters in. The blue clothes basket is sitting on the thing they were using to transfer, which was what they hauled out of the lobby, which was an actual bench that rotated. So it was causing them to fall when they were trying to get into the tub. So we'd seen things like this. We were called in to help with people that were struggling to manage their medications. People couldn't understand why they weren't taking their medications correctly. And we find things like this. So we'd seen a woman who had had a fall. This is Mrs. Bergen. She'd fallen after she'd seen the OT. No one could figure out why. But she was an amputee, and the therapist, instead of helping her get into her closet, had moved all of her clothes to the front, to the spare bedroom because it was accessible, which made perfect sense, except Mrs. Bergen then had to hop through the house without her leg because she put her leg on last after she got dressed. And so, all we needed to do was put a different hinge on this door and swap her wheels from the outside of her walker to the inside so she could get into her closet. So we'd seen lots of things like this. We knew a lot about the system from our partners who were in the community. And we had this community advisory board who are willing to tell us all the things that we were doing that were wrong. So we used all of that content. We really thought through barriers at the setting level. It's not offered here. What can we do? We find a national model for service delivery in the area agencies on aging. There's one in every county in the US. We thought about cost. We knew what costs were going to be affordable in AAAs based on our work with them in the past. And we knew that the AAA population was very different than the European and Australian populations that had received this intervention before. So we needed to think about that. So we went through at the provider level. We'd seen some of the things that I showed you that our providers were doing because they didn't have the skills to do this intervention successfully. We needed to give them advanced clinical reasoning really quick because this wasn't offered as part of standard curriculum for OT. And so we went through and we figured out which of these interventions we could build in ahead of time to make what our ultimate product be incredibly successful. So for at the provider level, for example, we created clinical reasoning guidelines for them to use. So we have a set of tools that they can take in to the intervention to deliver it with fidelity. We worked at the older adult level. We knew that older adults never think they're going to fall. Nobody sits around thinking I'm going to fall this week. So we had them help us figure out how to build in a sense of maybe I should consider fall risks into their daily life. So they told us to stop giving education about fall risks, and we invented fall prevention bingo for them to use in any community. If you're looking for an activity on Thanksgiving with your family, I'm happy to say that fall prevention bingo is on our website, and you are all welcome to download it and play a game if you'd like and learn about fall risks in your home. We also tried to design the intervention to be bomb-proof. So we wanted to make it opt-out. We wanted to make it super durable. So we put in place lots of strategies that we taught the therapists to make things stick for the older adults. We came up with this little intervention. It takes 2 to 3 visits and a booster session. The therapist walks the person through the house. They not only remove the barriers, but they teach people to manage their own risk in the future. So as we know, our houses don't look the same from Monday to Wednesday, and making sure that older adults knew exactly what to do to reduce their fall risks was what we did. It looked really simple when we were done. So this is Mrs. F. She was undergoing breast cancer treatment, lived in a townhome alone, had a great family, really high risk. She had some incontinence, some muscle weakness, and a lot of fatigue from her cancer treatment. So we went in and we saw that she had a long way to get to the bathroom at night. She didn't have anything to help her out of bed. She was very weak. So we installed some temporary kind of a commode so she could get up and use the bedside commode at night, and a handrail so she could get up and without falling. In the bathroom, we same problem as we see before. So a high ledge of tub, she was struggling to get over it and into her chair. She was struggling to get off the toilet. As my grandmother says, they feel like they get further and further from you. It's the older you get. We just did some simple modifications for her, just a tub transfer bench and some handrails, and she was independent. So that's what our intervention looks like. Everyone wants to know, what do we do? These are our most frequent mods: grab bars, we secure rugs to the floor. We learned very early on, if you tell people to pick up their throw rugs, you will be escorted to the door, so that you figure out how important that rug is and how to secure it. And we have millions of ways to secure rugs. Let us know if you need some. We use a lot of bath seating, toilet seating, but again, the profile looks different every time, and the finishes are always different for each person. So this is to kind of cut to the chase. This is our HARP study. We called it the Home Hazard Removal Program. We did this study with the Area Agency on Aging. We enrolled about 300 folks, and we randomized them to treatment or attentional control. And we followed them for 12 months and asked them if they had a fall over the phone. So this was a negative trial. We looked at our primary endpoint was fall hazard, or time to first fall, for a fall risk, and that was negative. But what we did see, and we actually looked at, could we reduce fear of falling? We did not. Did we improve quality of life? We did not. But what we did do was we had a 38% reduction in the rate of falls for these older adults. And what was even more important for this study was that we had called Tim McBride and Abby Barker, and we had done an economic analysis of this data too. And we saw that the per participant cost of HARP was under $1,000, so it's very low cost, but it had a decrease in healthcare utilization. So Abby tells us it's a 111% return on investment for the intervention, which was really exciting. So we also measured some process outcomes. And this is what I'm really actually pretty proud of. So 80% of the folks that we approached said they would do it. So that made me happy. 82% completed the study, which was for an aging study, and the red boxes made me happy as well. We had a 38% reduction in falls. 99% of the interventions were able to be delivered. We used strategies to help the therapist not say, we're going to pick up your throw rug, but how can we work together, and what kind of throw rug, what kind of rug do we need to have here? So we were able to engage older adults and get them to buy into accepting and then keeping the interventions. The other thing that we do, it sounds like we have really great adherence. I'm proud of it, but we screw things into the wall. It's hard to not use a grab bar if it's screwed into the wall. You have to be really intentional about not using the grab bar. So we have pretty high adherence. We kept the dose pretty minimum because we know that there were not a lot of resources in this group. So we were really efficient with how we delivered the intervention and the cost. Just for the modifications alone, we wanted to keep it under $500 because that tends to be the cap of what area agencies on aging are able to pay for older adults to have home modifications. So we were really happy about the process outcomes. So the rest of the story is we then went on to do a cluster randomized trial during COVID. So it was not, we had good outcomes. We were able to implement it, did not have quite the same effective fall reduction as we did in our first trial. But we were able to move this into an evidence-based program at the National Council on Aging, which sounds impressive, but really our goal was that we wanted Title III funds from the Older Americans Act to be able to be spent on this intervention. So this actual designation opened up a whole new pot of money for area agencies on aging to use to deliver the intervention. So that was kind of our plan, our implementation plan, to make it affordable and to make it deliverable in the US. So we were able to do that. Funny enough, we were working with our Madryn group, And we conducted a cohort study of these folks who are aging with disability. And these are folks that are 40 to 64, 45 to 64 years of age, who are aging with long-term disabilities. So we know that folks with disabilities have an accelerated kind of aging. So they're aging, they look at 45 like someone else might look at 60 if they've lived with their disability, maybe a spinal cord injury or cerebral palsy for 20 years. So they look very different and they have a lot more health conditions. So we put in a fall question in this survey that we did, about 400 folks across the state of Missouri who are an average age of about 57, who had lived with their disability for about 20 years. What stunned me was 65% of these individuals who don't have connection with the health system, who have been, rehab said, good luck, you're going to be great, we wish you the best. They, 65% of them were falling, 57% were injured, and 75% were worried about falling. So it was a pretty understudied group that had a big issue. So we worked with Madryn, with our group of providers, and we've modified and adapted HARP, and we're now actually, we're conducting HARP 3, which is delivering HARP for people who are aging with long-term disabilities in the community. So that's kind of one example of where I think the environment can make a big difference, and hopefully in HARP 3 will continue to make a big difference in how people are able to stay safe. So about this time, this is Carrie DeGroot, who was one of my students who, while she was working in the Rehab Institute, was moonlighting in my lab, delivering HARP. And she came in and said, why can't we give HARP to the people in rehab? And I said, there's reimbursement issues about this. So she told me the story of one of her patients who she discharged home, and he fell in the bathtub and sustained a brain injury. So he returned back to the Rehab Institute, and he did not have a good outcome. And so Carrie was talking about so passionately about this person who she thought had such great potential post-stroke, who really, his life ended. And it was horrible the way it ended, and it was horrible for her family. And she said, I'm in these homes with these older adults, and I'm in the Rehab Institute, and I don't understand why folks in inpatient rehab can't get the same thing. Well, it turns out very, very few people get in-home treatment post-stroke if they're in rehab. The rates of home visits pre-discharge have plummeted post-COVID. We see very, very few. And it's not easy for therapists to argue to make that happen. So we decided to try to help them out. So again, learn the new literature, hang out with stroke. But this is a really, we spend a lot of time talking about these stroke numbers, but it's really hard. It's easy to find. Every 40 seconds, someone has a stroke. 5th leading cause of death in the US. 1 in 4 are people that are having their second stroke. That's all true. We really are doing a great job of trying to do primary prevention for stroke, but we're not thinking about that secondary prevention. 1/3 of people go to independent rehab facilities, and 50% of those report waiting at home to get better before they resume their lives. So 50% are just sitting at home waiting to get better. We know when I started working with the stroke group, there were an average of 18 visits that you had with a therapist, and most of those were spent trying to get your left upper extremity to move again. So people were leaving without the ability to put on their pants or get into their homes or take a shower. Now it's 13 visits because of health insurance reimbursement. 13 visits from the time you get out of your acute visit at the hospital till the time you're at home, where the caregiver kind of staring at your bathtub, wondering how this is going to happen. So we went through the same process with our Compass group, and we developed an intervention based on HARP. 1 pre-discharge visit, that took a minute to sort out. So we were breaking people out of inpatient rehab, taking them home, doing a home visit, and then returning them to the facility, and trying to keep the therapist blind to what group people were assigned to, and then trying to sort through that frustration on the part of the rehab facility folks who were really couldn't understand why I couldn't just tell them what group people had been assigned to, so they didn't have to give them any of the treatment that they normally give them. So it took me a long time to build relationships with inpatient rehab, who are the most amazing therapists. They work so hard, so many hours to help people the best they can. But we did, and we conducted Compass, which is about 4 or 5 visits. We start out by helping people get super independent in bathing and dressing and those basic activities. And I wanted to make sure people got back to their lives. That's really why I'm an OT. So then we spent the second half of the intervention looking at community reintegration, getting back to church with your family, going to your granddaughter's basketball game, sorting through how you can manage the barriers in the community to be able to get back to your life. So I'm just going to start by saying it's never a good idea to have your primary endpoint be community integration during COVID. So that was our first mistake. But we were able to do Compass, and it took us a couple extra years because, well, the inpatient rehab facility shut down for a while. So things go. But we were able to do very similar things to what we were doing in HARP. You know, pre-Compass, toilet too low, you start to see a pattern here of the things that we do. Very simple things, very inexpensive things in the home for folks going up and down stairs. So this doesn't look like it's going to be a problem unless you have a stroke and you only have one arm, because you don't want to back up and down stairs one time. So adding extra rails, very simple things that we did. So again, another negative trial for this. So we didn't have any difference between the treatment group and the control group for community outcomes. But if you'll notice the little clipboard, which I'm not sure why JAMA made the clipboard our symbol for our attentional control group, we had to keep over enrolling our control group because we noticed that our control group was dropping out. So when we kind of interrogated why folks in our control group were dropping out, we noticed a few important things. So and I'm going to go back 1 second and just point out that our sample size was 185. So it's a very small sample size, but our pilot had shown great effects sizes for community integration. So we were feeling really good, but a pretty small sample size. But what we did find was, if you look at this survival probability, what we're looking at is days from rehab discharge to skilled nursing facility admission. Our control group was disappearing because they were actually being admitted to skilled nursing facilities. They were becoming institutionalized, which, if you work in stroke, is the primary outcome that you try to avoid. So we had a stunning effect that we never would have powered for in this trial, but this was one of our safety outcomes. And so we were monitoring death, we were monitoring falls, we were monitoring SNF admission. What was really stunning was we had a lot of deaths in our, we had 9 deaths in our treatment group. Sorry, in our control group. We had 1 reported death in our treatment group. But when Missy went back to make sure none of the deaths were due to COVID, we went back and we poured through Epic records. And we found that 1 person actually hadn't died. They were still being seen at Barnes Hospital. They just gotten tired of us calling them. So they reported that they had died, but they were alive. So I guess failure on one end, but we were glad to hear that they were still with us. So this kind of, right, you learn things the hard way, but this was another outcome that was pretty startling. So we were able to leverage this data to submit another application. Again, Tim and Abby are involved in this. So we decided to see if this is a true effect. So we're doing a definitive trial, and it's a hybrid trial. We're doing an economic analysis, a fully funded economic analysis, not the shoestring budget that we'd had in the past. And we're also looking at process outcomes for Compass to see if this will work. So it's also a multi-center trial. So we're partnering with 4 Encompass rehab facilities in urban to suburban to rural communities across all the way to Columbia. So we just launched our trial I think that we moved in September and then 2 weeks later launched our trial. So it's been a busy couple weeks. So that's why half of our team are actually out. Today we have 5 folks that have said they're interested in enrolling, which is another thing I'm really proud of, because we have a lot of therapists now that were so excited that we're back, because they were so thrilled with the partnership that we had, and they were so excited about Compass too, that we do not have any trouble now. They are on board. We, the first person that we enrolled, they held back from being discharged so that we can enroll them in the trial. So they were super excited that we're there. So that kind of leads me to, I think, impact is possible. Aging brings with it a lot of challenges and potential burdens. But I think the environment matters, and it's really powerful, and it's a potential prevention tool that we don't take advantage of enough. I do think the important thing that we know is that engagement drives success. We definitely partner with our community. And then just a note that planning for implementation is easier than trying to resolve implementation barriers once you're up and running. But you can't always anticipate all of them, like people telling you that they died and they didn't. So I'm gonna pause here and see if you guys have any questions. Yeah. Thanks.
I do have a question. One of probably people who have aging parents, and my aging parents and cared for refuse to leave their home with multiple steps, etc. And I did make a bad mistake suggesting living program. I literally almost got thrown out. And I'm related. I'm wondering with the changes in the environment, which we had tried to do something with them, did anything ever come up about pets? Because I had my parents love cats, and there was 1 cat, and there was 3, and there was 5, and there was a dog in there, and my mother fell several times because of being a cat. Did that ever come up, and did you find any way to navigate some of that?
Pets, yeah. No, absolutely. And I mean, it's a balance, right? Because loneliness is just as troublesome as, you know, smoking and obesity, and we don't, and pets impact loneliness. So this is the balance that therapists have when they go in. They are complicated systems. I mean, we have hoarders that can't give up their things. We have people with pets. We have people that have pet messes that also cause slips, trips, and falls. So those are the things that we can do as much as we can do in the environment, and we can only do what people want to do. The only fall that I had in my first study was the woman that was putting her throw rug back down after the therapist left. So I learned really early on that they're going to keep their throw rugs, they're going to keep their cats. So I can teach people self-management strategies. So they learn, I'm going into a room and I'm going to have to stop and look and make sure there's not a cat under my feet. We can also help them manage the cat stuff. So it's a systematic thing. It's not just we can remove the cat, but it's how you interact with the cat. That's the specialty of what our therapists spend time with.
Are there a lot of falls?
So there have been a couple articles. So sometimes people say, yes, it's like red wine. It keeps going up and down with, yes, it is a cause. No, it is not a cause in the literature. I don't know how red wine is, but I've limited my intake lately. Oh, and did Zoom hear that okay? I did not, okay. Okay.
This was terrific. Congratulations to you and your team.
Thank you.
So much work and all the collaborators, community partners. I'm wondering if do certain of the home modifications yield greater protective benefits than others? Like, can you analytically detect that?
So Matt, that is what my project officer asks all the time. Matt wants to know if certain home modifications, is there a certain magic bullet of home modifications that are more impactful? And I wish there was, but you start to see some patterns of, boy, we should have tub benches. But then if you're really a planner, maybe you should think, well, maybe we should have 0-step showers. so that we don't have to have tub benches. So you don't want to just look at the actual data, but think about the activity and what steps it takes. So there's not any one set of activities that we have found, but I can tell you that we frequently prescribe more grab bars than anything else, but I never put them in the same place, right? Everybody uses their space a little bit differently. And then as soon as we figure out how people use their space, then you have the complication of people want to live with their family and they're using the space too. So that makes the modification a little bit trickier. You can't raise the toilet seat up to 22 inches if there's a kindergartner in the house. You know, you've got to think about those kinds of things. Does that make sense?
Yeah.
Yeah, it's all precision home modifications.
Can I ask another question out of some way? So I'm curious about, you know, you sort of led this off with, you know, people who bought, you know, their homes with like GI Bill funds and so on, like they weren't designed for, you know, octogenarians. Are the homes being built now better and different?
Mhm. The homes being built now are in some cases better. I would say Europe is leading us on policy for having things like a 0-step entrance, but there are some communities and municipalities. It's you know, state by state, community by community that have made some of those requirements. We don't balk at the fact that we all have to have a heating or plumbing in our home. It seems crazy to me that we do balk when people say, build a home with no stairs, so you can get in if something goes awry, and make sure there's a bathroom on the first floor. But there's been a lot of pushback with regard to, you can't tell me how to build my home in that world. So some municipalities, and there are different levers, right? You can incentivize builders who then will put the modifications in to make things more universally designed, we call it. Or you can incentivize homeowners that might get a tax credit of subtype. But every community does this a little bit differently. So there's no good overarching national policy.
It's really interesting. I'm just wondering about, kind of related to Matt's question about renters versus owners, and also like you're renting a place for staff.
So the question is about renters versus owners. And so we have had pretty good success. People told us reviewers said you can't do home modifications in rental units. And in fact, you can. In the past, we had fair housing laws. So any unit of 4 or more units would be required to allow renters to make changes. So you would be able to put in a ramp or a grab bar. Fair housing also required that you put enough money away to reverse those changes if you leave in escrow. So that, but we've never actually had anybody reverse the changes that we've made. We find actually older adults are fantastic tenants and that landlords want to keep them. And if we help tenants advocate for themselves and explain what's needed, and the landlord doesn't have to pay for it, that they kind of perceive it as a benefit, and their unit will be more marketable for older adults in the future. So we've had pretty good success with a lot of folks. I would say with our younger folks with disabilities, we've been having a few more troubles with that group in HARP 3 than we've ever had with the older adult group. But so mixed, I'll let you know how HARP 3 goes in another year, and we'll see what happens. That's a great question.
Hi, Susan.
Hi, Patrick.
Really cool. And you're doing homelessness prevention.
Right. I started there. Yeah.
So this is so intuitive. And it just begs the question, why don't we do this for everyone? Are there places in the world that are doing this for everyone? Are there strategies to scale?
So, so the question is about scalability and why aren't we doing this? It seems pretty intuitive. Yes, after I got off the phone with that insurance company so long ago, I was so mad, and I was in a training program early on, and I shared that story with one of my fellow trainees, and I said, you know, we've never had a randomized controlled trial of penicillin. I do not know why we have to have a randomized controlled trial of toilet seats. That seems crazy. But other countries do it better. I would say the European countries, Western countries, Australia have more of a system of how we support people in the community. But that's a different model of care than we have in the US. We've not figured out how to scale that yet. There are lots of policy questions going on, and we actually have a few folks that are interested in the topic that might be able to bring legislation, but we've had such turmoil in the past few years that none of that legislation that we have planned for some of these modifications being part of how we deliver service to everybody that gets healthcare haven't come to fruition. So I agree. The numbers seem pretty obvious to me when you look at the scale and scope of who we're able to help, but we haven't been able to crack that code yet. Amanda, now I'll come up to you.
I think this is really cool. I worked in the hospital and I feel like discharge planning at one point with her, and I'm thinking when you mentioned you can break them out, that's what we have to go home to the assessment.
I fully had permission. I shouldn't be so sorry. We had a day pass, but
I'm wondering affecting that, like if you know, bringing people home is really hard to do, and bringing them back, where there's questions or something that you can do to kind of affect the home better, or a way to do it so that things are.
right. So I should say for Compass, we do put all those things in place before they get home. That's the cool. We would like get them tub benching, and so they could be able to make a meal, you know, take a bath, use the bathroom, get in and out of the house. We made sure that happened. And we did during COVID have to do what we called access visits, which meant that the therapist would meet the person, get to know them a little bit, and then go check out the home and try to do that person environment fit in their head. We don't think it works quite as well. And I think there's other benefits to taking a quick trip home to see what your environment's going to be like with your new body for somebody that's experienced a stroke. Because in your mind, you're going to be able to do all those things that you were able to do pre-stroke. You might be worried about the steps in the front door, but you really haven't thought about the subtlety of how you're going to get up the stairs. Where's your walker going to be? And are you going to have a second one at the top of the stairs? You know, like all of those things suddenly become like, oh, maybe rehab, I need to spend my last couple days here thinking about what I need to put in place skill-wise before I get home. So I think there's other untold benefits, even though it is expensive and it takes a minute. And that's a testable question about whether access visits or the actual person going on the home visit is important. I should say back in the olden days, a lot of folks who were coming through rehab, if they had pretty significant impairments or might have big challenges at home, were often granted home visits. So what we're doing is not super innovative. It's just actually care that we provided in the 80s and 90s that we lost during COVID. So it's kind of going back to what our practice is. And it's actually listed in the stroke guidelines as one of the things that the therapist should consider. So good question. I don't have the answer for you. Thank you. Very good question. I don't have a clock. How are we on time?
Oh, no, one more.
Oh, one more question. Okay, behind me.
Going back to the intuitiveness and the obviousness, individual changes for individual. I'm curious, you know, how do you explain the null results with your, you know, attention control? Is it too much of a control intervention? Are these just too big of an intractable, or, you know, changing you know, we're not going to completely get rid of falls, we're still having falls, but maybe we want to reduce them, and that's the problem, you know, kind of hours. We've had the same issue with, you know, addressing social determinants or needs. You can make some dent, but, you know, there's no significant difference, maybe because of the size of the problem. And we thought about that.
Yeah, so falls are funny because they're multifactorial, right? So some people might have orthostasis, and I can't fix orthostasis with I can probably stave off some things, but not all things. Or if your blood pressure is going to bottom out, I can teach you to sit at the edge of the bed before you get up, but in some cases it's going to be a problem. Sometimes there's visual impairments that I can do a great job while you're in your home, but I can't fix the community. I can fix your behavior, but I can't fix the lighting at the movie theater, right? So there's just some things that I can't do. There's also things like home modifications are just one intervention. And if you want the whole fall talk, there's balance and strength, the other impactful and powerful intervention that we have in our back pocket. But I probably don't need to tell you it's really hard to get people to exercise. So home modifications tend to have a bigger effect size because they're durable and we screw things into the wall, and getting people to show up at their exercise class every week is a little harder. But there's other multifactorial issues that are, and it could be fine on a Monday, but if you're hurrying up the steps on Wednesday because somebody's knocking on your door, that's when we have a problem. So it's hard to reduce all falls. I also think there's other fall risks that we don't even know about yet. We study Alzheimer's disease and people with preclinical Alzheimer's disease that have abnormal protein deposition in their brain. They have higher rates of falls than, they look more like our folks with long-term disabilities than their age-matched peers that don't have preclinical Alzheimer's disease. So there's other things that we aren't even measuring yet that probably we need to better understand, is my best guess. All right, thank you guys. This was great.